Good morning, good afternoon, and good evening. And it should be, of course, Professor Chi, who is so nice to be with us also today, saying that because indeed I'm quoting the opening statement he has been doing all along the 2021 online educational activities of bwin. Of course, we are at the end of the year, so it's time to wrap up some good memories and look at a good future. I really like a statement that is saying that if you want to know your present, you should look at your past. If you want to know your future, you should look at your present action. And who better than Professor Caprini to tell us the story of how we got to today public venous awareness in terms in particular of thrombotic risk assessment, and who better than Professor Caprini to tell us the direction to go for the next year in terms of research. So first of all, I'd like to deeply thank Professor Willie Chi for being with us today. Good morning, good afternoon, good evening, Willie.
Yeah, hi. Hi, Joe. Hi, Sergio.
And good morning, good afternoon, good evening to Professor Caprini. Thank you so much for being with us. And of course, we couldn't be here if it wasn't for Khaled Zidan, who is now a dear friend, part of the family, part of this educational teamwork, who we deeply thank for being with us in representation of the public, because in the end, indeed, our first aim is to reach to our patients, even if Khaled, luckily for him, is not our patient and is luckily for us, our friend. Ciao, Khaled. Thank you so much for being with us. So the idea is to wrap up in 15 minutes, very important messages on public venous awareness, starting, of course, with the pillar of that is, for us, the Caprini score. And I've always been curious to know how Joe came with this brilliant idea, when it came to his mind to start this long process that allowed us to properly treat our patients today, as for the T-shirts that actually Khaled is wearing and that Joe is showing in his backdrop about never killing a friend and never treating a stranger. So that we will never kill, let me say that again, never kill a friend, so that we have to treat our patients in the proper way as if they are friends, so not treating them as strangers. Joe, how did you come up with this idea?
Right. Well, first of all, it's a tremendous honor to be with all of you, and it's a tremendous honor to be a part of this bwin Foundation. This is truly bringing the world together. And this is so important now, especially in these times with this disaster with COVID, that we all come together. And maybe that's part of what's going on here. But I would like to say that I was just walking along, singing a song, and I was at the right place at the right time. The first place I was at was with during medical school with my beautiful wife, who at the time I was courting her because she was the chairman of the, she was the department chairman's executive secretary at age 18. Brilliant, wonderful lady. Here you see her in the palace in St. Petersburg. And this was my medical school years. And of course, I met Dr. Wilbur Oakes, who was an incredible diagnostician. And in those days, we didn't have D-dimer, we didn't have troponins, we had no CAT scans, we had no MRIs, physical, history and physical. And I would go around with him, he would take me around with his students, and he would teach us things, and he would extract the history from the patients. And I was just in awe of his ability to extract that information. And that was sort of the start. And then I was lucky enough to go to the University of Liverpool for a semester during my medical school years. And while I was there, this was a very low rent situation. I had a little photographic business, which I sold to buy a ticket on the Queen Mary, which was $300 in those days. And I stayed in the World Friendship House for $11 a week. But I made rounds with the students at the University of Liverpool, and Ian McPhee, the chairman of surgery, would come on the ward at 8 o'clock in the morning, and he'd take the students around and he'd show them various things, stand a person up and watch them breathe and look at the slips of the diaphragm in the window, and various problems, physical diagnosis problems. And also, I remember going to St. Thomas's, and I remember John Hobbs said, "Welcome to St. Thomas's. This hospital started 30 years prior to the Battle of Hastings, which meant 1036. And it taught us about the Kipple-Trinani syndrome, which is a very complex syndrome with varicose veins and so forth. All of this I was getting in the background, indoctrination, without really realizing what was going on. And here is what set me up for life, this beautiful lady, very good year. And now it's almost 60 years later, and she's been at my side and been a good advisor and counterpart through all of this. And then I took a straight medical internship because I was enamored with Dr. Oakes. And so I wanted to find out more about histories and physicals. And we would go on the ward on a Sunday, and he'd spend an hour or an hour and a half taking a history and physical and writing it up. And then the next day, the attending would come in. And in about 10 minutes, the attending would pull more information out of the patient than we got in an hour and a half. It was like, wow. And then came along the Vietnam War, and I was recruited into the Air Force, and I had to operate on children in Montana. And I was afraid I'd operate on a bleeder. So I did some screening tests for bleeding. And the corpsman did the tests, and we were able to avoid any bleeders, but it was very successful. When I came back to the hospital, then I had to take 6 months of research because we were now affiliated with Northwestern. And I studied bleeding patients, patients that were coming in bleeding into the emergency room. They would get them ready for surgery, and I would go down and do the tests. And I was able to cancel surgery on a third of a group of 50 patients because I was able to correct their bleeding with blood products, which I had learned by that time. And so that I started a special coagulation laboratory for the hospital, and we studied over 100,000 patients over the next 25 years. But doing that, we come back to the Caprini story. I started to work with the TEG and do thromboelastographic research. So then the Kendall Corporation reached out to me, and they said that we have this new devices that squeeze the legs, and we've been told that they stimulate the blood, and we want you to use your measurements to see if you could tell us, characterize what's going on with the compression devices. Well, we did that. We spent 20 years working on that. And of course, it stimulated fibrinolysis, but that was a very complicated story. But what happened as a result of that is in 1986, I was invited to go to NIH because I had the first conference on DVT and thrombosis awareness. And I was representing compression because I had been doing pneumatic compression now and studying it for 10 years, including using it in our hospital. And after the conference, I went up to the people that made the devices and I said, look, you need to do a trial to show that these devices are very good. They may be good or better than anticoagulants in certain situations. And they said, no, Dr. Caprini, we don't have the money for that. But why don't you put together a list of risk factors that could cause a blood clot? And these were 3 nurses and a PhD. So we put that together. And we listed all the risk factors. And then the next thing that happened is that I was able to meet Maxwell Borrow. And Maxwell Borrow, in 1981, he was a general and vascular surgeon. He did a series of 1,000 patients, and he measured, the end point was venograms in these patients. And what he determined was the basis for who develops a blood clot. And the incidence of blood clots, as you can see, if it's 1 to 2 hours, 20%, and then 2 to 3 hours, 46%, and so forth. The same thing with age. And he also made a blockbuster comment, which we're still trying to get through to people today. 66% of patients who had a past history of VTE suffered a recurrent thrombosis if they had an operation. And so these were the building blocks that we put into this, incorporated into this score. And then coming back, so if I can just summarize here, the experience with Dr. Oakes at Hahnemann, the Liverpool experience with Ian McPhee, the Evanston Hospital experience doing the histories and physicals, Maxwell Borrow, and the NIH Consensus Conference, put all of that together. And then along came Juan Arcelis and also Gail Size, who was the vascular tech. And together with Sandy Candosia, they studied 1,000 patients at Glenbrook Hospital. And they did Caprini scores when they were admitted. They did Caprini scores. And they showed that you could determine which patients got a clot and which patients didn't get a clot based on their Caprini score. And so right away, this started to be picked up by other countries because a lot of countries have national health insurance, and they could figure out quickly who could they avoid giving anticoagulants to and who could they give anticoagulants to avoid having to treat blood clots, but not in the US. They wanted none of this. Even up to 2008, Bill Gates said, we don't recommend you do this individual risk assessment. We don't know what to make of it. It's hard to characterize. You need to do risk assessment according to types of procedures. And of course, that's the other blockbuster message that we're still trying to get out. You have a risk of blood clots from surgery, major surgery, minor surgery, hip replacement, high incidence, knee arthroscopy, low incidence. But that's not the answer. That's half the answer. The other is the baggage that you bring to the operating room. And that's why this Caprini score was able to measure that baggage. And sometime a low-risk patient that has a lot of baggage would be even more at risk than a high-risk patient that had little baggage. Well, anyway, we roll ahead to 2008 when I gave grand rounds at the University of Michigan. And as a result of that, they studied 8,200 patients and showed the Caprini score really worked. Based on that, the CHEST 2012, and now Bill Gates was gone, and there was a new Dr. Gould and a new group of people in there, including my fellow. Of all things, why was my fellow invited to be part of that? And so the Caprini score was then recommended as a possible score. Following that, in 2014, came the other really blockbuster event, and that was Boston University. And I don't have a slide of this right now, but Boston University said, we're going to do the Caprini score in our patients because we have a high incidence of thrombosis. And we're going to make sure that we develop an algorithm. So if your score is less than 5, you can do whatever you want in the hospital. But if your score is 5 to 8, you need to give 7 days of prophylaxis with low molecular weight heparin. And if your score is 9 and above, you need 30 days of low molecular weight heparin. And the other thing is, this is the other thing we're trying to get out to people today. And that is that just because the patient gets out of bed or goes home from the hospital doesn't mean you can stop their thrombotic program. Because if you take a patient and they get out of bed, the only risk that you improve is bed rest. If they have cancer, if they have inflammatory bowel disease, if they have a past history of thrombosis, doesn't change any of that. And that's where you can use the Caprini score to evaluate how risky it's going to be based on their level, so that we know that these patients that got 30 days of prophylaxis did much better. And so what was the conclusion in Boston? Boston lowered their incidence of all venous thromboembolism on the surgical services, 30-day results, including deaths, to 0.1%. It was an 84% relative risk reduction. And what they also did is they made a deal with a drug company so that anybody that needed the drug would get it regardless of their ability to pay. Now, if every hospital in the United States did that and had an incidence of fatal pulmonary embolism of 0.1%, what a wonderful thing. So that's the message we're trying to get out to the public. Boston University has written 15 papers on this. So now what I would like to say is that's been a very fast forward. And just to show you how things take time, right now we have over 240 articles in 25 languages all over the world. And but I want everybody to understand one thing. It's not about Caprini. I was at the right place at the right time and surrounded by all these brilliant people, including this last slide here, which they gave me when I retired from clinical practice, but Alfonso Tafur, this brilliant investigator that came with me. I was surrounded by all these brilliant people and listened to them, and we all put stuff together as a group. And this is a message for the world. You've got to get together. Stop competing with one another, criticizing with one another, making fun of one another. Join hands with each other. And when you join hands with each other, you can do things like this, like we were able to do. And as I say, I've just been the messenger carrying this message. But I think it's been a very, very wonderful and productive thing because we're saving lives. And it's such a great thing. I'll stop here.
Oh, well, you should never stop, of course, Joe. And thank you so much for being such a good coach of what we hope is a team. That is indeed one of our quotes, saying that players win games, but teamwork wins championship. So in this championship, What would you suggest us to do next for the 2022?
Okay, this is very important. Number one, you've got to collect all of the risk factors. Now, that's a very difficult job. So we have to use artificial intelligence. We have to use voice recognition systems like chatbots. We have to encourage patients to fill out their risk assessments, take it to their doctor, put in their record before they get sick. And then when they get sick, that number is sitting there. So that's step one. Step two is mandatory implementation of care pathways. We have plenty of information to know who's going to get a blood clot. We don't need more data. We know who's going to get a blood clot. But to take that data in an algorithm and make sure it gets applied to each patient, that's the key, mandating implementation. Now, in order to do that, my other suggestion is, and this is what I think is really, really cool, is you don't stand up there as the chief of surgery and start yelling and screaming like, here I am, blah, 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 blah. No, 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 no. You use a nudge. Now, what do I mean? Well, there was one of the states in the United States decided to put on their license, if you want to donate your organs, check this box. 40% of people check the box. So now they said, well, that's not very good. So let's do it the other way around. So they made a new one that said, check the box if you don't want to donate your organs, 80% compliance. The nudge doubled the rate of compliance. So how do you do a nudge here? You set up a mandatory, you pick a unit, and a researcher will follow every patient on that unit for 90 days. They will do a Caprini score in the background on every patient in 90 days. At the end of the 90 days, they will correlate how many people get clots, what are the outcomes, all in the background with the permission of the doctors. The doctors will do whatever they normally do. No influence on anything. Here's what you do. And then at the end of the 90 days, you bring them in and you say, well, now look, your results are 3 times what would have happened if you'd have used the score. So why don't you try to do this for the next 3 months and see if it will improve your results? And you can always opt out if there's any patients you don't want. If you think we're not twisting your arm, but let's try this. That's a nudge. And I think that's the way to get it done.
Thank you so much. And now let's go to Willie, because when we are talking about science, it's really the person to look at too. Willie, would you have some comments on this unique opportunity of speaking with Joe at the end of the year?
Well, yeah, thanks. It's certainly an honor of mine to have Joe as not as a mentor for all of us, an educator for the world, and certainly a luminary, but he's a true friend to all of us around the world, including the V1 Foundation. So Joe, let me ask you this question. Looking forward to 2022, we only have a couple more days left. What do you see as the most pressing thing in terms of thrombosis research in the next upcoming year?
Well, there's another side. Because of time, I didn't get into it, but there's a concept of it. We can't be just stapled to the guidelines. We have to try to get the message out that the guidelines are based on average risk patients where there is equipoise between and you can have a control group. Most of the patients we see in practice are very high risk. They can't be in a control group. But yet, if it doesn't fit the guideline, do you treat them? So we have to have some educational activities, and nowhere better than the VWIN, to educate people that just as important as the guidelines are clinical practice experience and results. And for example, a man falls on the motorcycle and crushes his leg. And the guidelines say, we don't recommend routine prophylaxis for lower extremity distal leg fractures. Well, the man goes on and dies of a blood clot because he didn't have the crush injuries weren't in the guidelines. There are high-risk patients. You must treat patients with crush injuries. So then telling that story, and hopefully if I stay healthy, I'm going to start a series on my YouTube channels of those little clinical vignettes. And I'd love if we did this together. I've got about 15 clinical vignettes that I could tell you about, starting with that motorcycle story, or a patient that comes in with an appendix, a simple appendix, but then gets a wound infection, gets pneumonia, leaks, and has to be reoperated. And they say, oh, well, we don't need prophylaxis because her Caprini score was 4 when she came in. Now it's 11. And then she dies. So I would say that what I think we need to do, and I'd love to do it with you all, is this, is teaching people about not only the importance of guidelines. Of course, if the patient fits the guidelines, mazel tov, but many times they don't, the value of clinical experience.
Joe, another thing we are used to say is that it's not just where we are going, and of course we are going to Dubai very soon, but also whom we are traveling with. And we are lucky enough to travel to Dubai with Khaled, who is here to represent the public, and I'd like to deeply thank him because nothing would have been possible without a very professional support behind all the activities we have been running around the year. So Khaled, I was asking you once, what do you do in case of a red swollen limb that is happening to you right away?
Now, before first of all, thank you for this honor to be with you here. Before I met you and before I hear all of this educational activities which we have done together, I honestly did not know where I have to go. And
sure, it's not you, because indeed it's a leading cause of preventable death that is indeed preventable. So it's our responsibility to be over here reaching out to the public. So is there something as a communicator that you are like, and as an organizer you are, that you'd recommend us to do more as physicians in this term? Like to reach out, and maybe we are speaking just among ourselves. Maybe we are not using too easy terms.
To educate us more.
Yeah, and that's what that's what we will do. Also, thanks to you. So we look forward for being together in Dubai in a month and few days. And until then, I will leave the mic to Joe for the final message of the end of the year, because this is a little bit of a present that we are trying to deliver. Thanks to Joe with a good message for the end of the year, indeed.
Well, thank you very much. Again, it's a great honor to be associated with this foundation. And this foundation has really brought the world together. And the final message for this year, Sergio just said it. And that is, there's a lot of complications that occur after an operation or hospitalization that we're powerless to combat. Not fatal pulmonary emboli. If the patient is risk assessed properly and given prophylaxis, we can show you with statistics that the chance of dying from a fatal blood clot is 0.1%. Yes, you could still get a blood clot, but the fatal events are about 0.1% if you use the proper prophylaxis in the proper patient with the proper risk for the proper amount of time. And that amount of time isn't 2 or 3 days. It's 7 to 10 days, minimum 30 days for most patients. And again, I'd like to thank you all for this great honor. Again, if you will, I'm at the right place at the right time to be with all of you wonderful people from around the world, and I truly appreciate it. And I would say in final response to every person in this audience, be very, very attentive to your surroundings, and you have instincts. Sometimes I will call them the higher power talking to me, but you have instincts. Follow your instincts. Make sure you're doing good, and join hands with your fellow men and women at all times, and let all the distractions and all the criticism, let that all go away, and just join hands with one another and move through life, and you will have a very happy and productive life.
And with this, we also deeply thank, of course, Professor Bottini, who is in the operating room now. So I'm sure he calculated the Caprini score before, so there will be safety over there. The mic goes also to Willie for a final message at the end of the year.
Well, thank you for listening to everything that we have done over the last year or two. Certainly, we learned a lot from Joe, during this period of time over COVID. I wish everybody a happy holiday and stay safe.
And then the mic goes to Khaled, because indeed the next time we'll be live together with Khaled from Dubai. So Khaled, the final message from you.
Wish you all a happy holidays, and I'm looking forward to meet you all in Dubai soon.
So again, thank you so much, everyone. Have a nice end of the year, and see you in 2022. Ciao. Bye.
Ciao.